I thought if we just start by rewinding back to the beginning, I don't know if you remember, so this is pre-COVID, it's about 2 years ago. We, as in the ELF and the CCG, put in a bid for this completely new way of working. So community mental health has really not changed since it was first set up like 3-4 decades ago. So this was the biggest overall overhaul of the way that CMHT works in, as I said, in a few decades. So it's not a small scale change. And I think we were quite brave to step up to be one of the trailblazers for that. So I think by being one of the few, the first people in the country to do it, to do this transformation, I think we knew that there would be difficulties, challenges, and things that we would learn along the way. And I think if we just go back to kind of the key aims of the transformation and forget about kind of the nuts and bolts at the moment, the aims and aspirations of the transformation were actually quite firstly very aspirational and quite noble. So there was no wrong front door. So any patient who needs help would get the help. Reducing barriers, so between primary care and secondary care, reducing barriers between physical health and mental health, doing away with this, complete medical model, because we know, the old style of having a GP, a psychiatrist, and a CPN, is not what our patients need. They need something much wider than that. And also moving away from diagnosis. So it's not just about you have to have this diagnosis to meet this threshold to get into a service. It's about clinical need and clinical complexity. So anyone who has the need will be seen, and also the team would be such that they could fulfill that need. So you can imagine this is a large, it's not only a system change, it's a culture change. And I think over the last 18 months since we've been doing this, there've been lots of ups and downs, and I think what I've learned along the way is that the system, the chairs are quite easy to change from place to place, but the culture is the hard bit to change, and then to make things change, every single one of us have to be part of that change. So I think it kind of brings onus to ourselves that we need to kind of embrace this new culture in the aspiration that this will be better for our patients. I mean, I could go on about things that have lots of things have gone well. There have been things that we definitely could have done better, and I would just want to spend literally a minute to talk about some of the highlights I feel over the last couple of years. So one is actually the new staff that we've had within the PCN space. So these are roles that have not existed before. So community connectors, more peer support workers, and these roles called community assistant psychologists, which is again a completely new role. A new university course was designed for them. So they're kind of like PAs, but for psychologists. So that's meant that there's a lot more people around that can help our patients in the way that they need, in the wider social determinants of health. The other thing is working more closely with our mental health colleagues, which I think those who are more into who've started the transformation earlier will definitely, I think, agree that they have got those better working relationships. And then one particular kind of highlight for me is some of the work that we've done in terms of BAME equity. Just forgive me for using that word, but I'm not sure what the best word is at the moment. But the amazing thing about the work that we've done in this arena is that there were some really high quality focus groups done within BAME patients about the experiences of community mental health. And those who led on this were people from these new roles. So they were community psychologists, and they were our peer support workers and our people participation leads. So we're now trying to implement those changes. So it's not just about talking, and we've got some really key themes that we've got a task and finish group which has just started to try and implement those. So really embed these things within our systems rather than just a kind of a side tick box exercise. So my last point is just that there's a go live date you may have heard about, which is the 9th of August, which means that those PCNs who don't have a PCN blended team who aren't working in this new system will start to work in this new system. Most of us have already are in that process anyway. There's a few left who haven't. But just to kind of emphasize that that's not the end of the journey. That is actually the beginning of the journey. All this has just been the prelude and working up to it. So kind of the iterative working, the improving as we go along doesn't stop there. I mean, and hopefully it will just carry on and continue. So those are just a few things I wanted to say. As you know, I could talk all day about mental health. I'm going to pass it over to Michael. So Michael Jones is now the program director for the transformation in Newham, but many of you may know him from his previous role where he was a commissioning manager at the CCG for mental health, so knows a lot about Newham and mental health, and he's going to run through a few nice slides and hopefully make it clearer some of the things that I've talked about. So over to you, Michael.
Thanks, Imrana. Hopefully you can see the slides on my screen. I'm not 100% so yes, I'm going to just speak for a few minutes on some of the detail of what's just happened with the go live day, and Imrana's really covered a lot of what this slide says, which is setting the context around this really major piece of national legislation and policy on community mental health services, and the really significant amount of money, new money, which is going into this area of the NHS. I think it's close to £1 billion by 23-24. And just to reiterate Imrana's point, we're sort of midway through this journey. And in a lot of respects, we're just at the beginning with the creation of these teams. Some of the really challenging ambitions of the program, which you see on this screen around dissolving boundaries between organizations and moving away from a referral culture. A lot of that tricky cultural behavioral work still to come, but it's kind of the work really starts now that we have the team. And the kind of the funding and the work just continues over the next few years. So as Imrana said, we've been doing a lot of testing since we got the funding and during the pandemic. So we had our pioneer PCNs that were South 1 and North Newham. We've gradually been expanding this way of working, some of the PCNs in North East. But as of the 9th of August, we went live with our 5 PCN blended teams. So there's 3 in the North and 2 in the South, and this slide just shows you which primary care networks are covered by each of those teams. So generally speaking, a blended PCN team will have 2 PCNs under it, other than Stratford. So it's just a one-on-one. Those teams are led by a Band 7 clinical lead nurse, who hopefully, GPs and PCN clinical directors will really get to know and start to develop relationships with. And then within the teams, they'll have a nursing and a variety of existing and new professionals. And these teams are made up of our old ABT and EPCS services. So those staff and those relationships that you'll be aware of, those people are the people that are making up these new teams. So far, as Mar said, there's been a lot of recruitment. There are lots and lots of new and exciting roles that are making up these teams, and a big part of the program is thinking differently about our patients and what their needs might be and how we can meet those needs. And that might not always necessarily be in traditional ways through nursing and doctors, but through some voluntary sector interventions or through some more psychological interventions. So there's been a huge amount of recruitment and investment in new staff. We've been gradually recruiting to new mental health PCN GP clinical leads who are really, really important in being strong advocates for their local PCN mental health team and helping to kind of forge those relationships with the new team. And then obviously in the future, we'll hopefully have mental health R's roles that will be another key part of this kind of local mental health team being set up. Just to give you a bit of an idea of what those new staff make up. So there has been some additional investment in nursing and medical time, but the vast majority has gone into these new CAPs or clinical associates in psychology. And they're really leading the way in delivering new types of interventions for disordered eating and complex emotional needs, or what has previously been referred to as personality disorder. Particularly these areas that we know in the past, mental health services have maybe not been delivering the best care for some of these patients, or these patients have sometimes struggled to access services the way that they're currently configured. Another really huge area of investment and priority for these teams is the voluntary sector and our community connectors. So there'll be 2 community connectors for each of the 5 teams this year. Peer support work is another massive part of the program, and we have, I think, 13 at the moment, but that's continuing to grow all the time. We have 2 healthcare assistants to support with the kind of my physical health screening and intervention within primary care teams. We have our own substance misuse worker. We will, in the future, have social workers joining the teams later on in the year, which I think is a real massive step for mental health care for so long, because we've existed in disintegrated services. So I think that's a real massive change for patients. And then, you know, we're recruiting all the time. So we had our mental health pharmacist start last week for the PCN teams. We've got an OT in post. I'm currently writing a JD for another psychologist to pioneer some work on at-risk mental state. So it's really exciting, and it's growing all the time. So in terms of the more nuts and bolts of what's just happened, as I said, on the 9th, these 5 teams went live, and so the big change for primary care is that we've gone from having a single point of access where all referrals went to our single point of access that was borough-based, to having 2 points of access now, which is if a patient is in crisis, that they need a response within 4 hours, that goes to the crisis services. So the number and the inbox there that you'll be familiar with. Whereas now, for those patients that are non-urgent, that can go through that ABT pathway of 28 days, or between kind of that 4 hour and 28 days, that they go to your local blended team, so one of the 5 teams, and there's been an inbox set up to receive those referrals. Another kind of key interface that we're really wanting to promote is the huddles. So these are MDT meetings with primary care and your local mental health team, really to discuss some of the most complex, difficult patients and cases, maybe where we're struggling to get the care right ourselves, and we need to come together and discuss that. So that's a space where the whole MDT comes together. So the psychiatrist is there, GP comes along, community connectors there, and they have an MDT discussion around some cases that GPs want to discuss. And they're just some of the times that are set up at the moment. So generally they're every fortnight. Some PCNs have opted to go monthly, and it's really up to local determination as to how PCN teams want to operate these. And key to these is the mental health PCN leads, who can start to shape how their PCN wants to use this time, really, and what benefits them and their patients the most. In terms of these huddles, we really wanted to build on the real positive working of EPCS, so having really quick, rapid access to expert advice from a psychiatrist or a psychologist, trying to move away from a kind of referral culture of back and forth, and, you know, GP sending a referral to ABT and ABT sending it back saying, no, they don't meet your criteria, or you need to do more work, and what have you. So trying to create that space where we can work together on our most challenging patients, and also brings in, hopefully, these additional voices, so social workers, substance misuse, so we can better manage these patients that don't fit into our nice NHS kind of boxes of need. And then finally, just in terms of another key aspect of this program is wanting to be more responsive to deliver care to patients at the right time. So the screening is going to take place on a daily basis by a clinical lead nurse for referrals. I say huddles we're looking to do fortnightly, and NHC England will be announcing this year 4-week waiting time target that will be applied. So that 28-day response from a referral to assessment is absolutely key to this programme. And I think I'm going to leave it there because I want to give some time for questions.
Thanks very much, Michael, and sorry I lost signal in the middle of that, but I think I've got the slides and stuff as well. So I didn't see any particular questions in the chat, although I noted, Laura, you've got a event that you wanted to share information on. Anil, did you, wanted to know a little bit more about the role of the leads for PCNs?
Hi, Karen. Hi, Michael. I just wanted to find out what the role is for each PCN. Obviously, has got a lead. What is that lead's role, and how do they fit into the PCN as such, or what is their remit, or do we then refer our cases to that lead and that lead discusses it and then implements it within each practice within the PCN, or because we still haven't got any clarification, because I know that funding is still being carrying on. Is that right, Michael, till the end of next year? There's quite a large sum of funding, which just wondering what it's for and how it's used.
Yeah, so I'm happy to share. There's a bit of a job description for that role with this group. So the funding this year is for each PCN to have a GP lead 1 session a week, and that was in recognition that there's a lot happening this year. There's a lot of change that impacts primary care, and we wanted to make sure that they had the capacity and leadership locally to input into that. Moving forward from April next year, those hours a week will reduce, but there's still funding and a commitment to resource local GP leadership for each team. I think to answer your question to what the role is, for me, it's a lot of it's around leadership and advocacy on a local level, so that primary care has a really strong voice in those huddles and in the developments of the team. And then there's also something about bringing the PCN together and a kind of liaison function and kind of helping with that engagement side of things. But Imran, I don't know if you're better placed to answer that.
Yeah, thanks, Anna, for the question. So if I just give you a little bit of context, in the different transformations in different parts of the country, many of them haven't put in this money for mental health GP leads. So we thought it was really important that we get that kind of primary care voice there. And so and I have to say, so we've got the funding for that, and it is fairly generous. It's 1 session a week at the moment. And I think probably retrospectively, initially perhaps the role wasn't structured enough, because I think the assumption was that a GP is senior enough to be able to take that leadership role, whereas I think through the last few months we've realized, of course, that's not the case. We need to build our leadership and develop them. So so although obviously, for clarification, I'm not a PCN mental health lead. I work obviously for the CCG. I've organized some kind of leader peer support groups, and so hopefully the kind of remit of the leaders is clearer to them. And exactly as Michael said, what we didn't want is like kind of a task-oriented, role for them. It's kind of a flexible role. It's about, firstly, it's about engagement and being the change maker within the PCN. So it's not about kind of sending individual patients to that person, to that GP lead, because they're not a gypsy in mental health, but it's about kind of them knowing the system, advocating for what's best for their PCN. And so this is not meant to be like, this is a model, bam, your PCN has to implement it. It's about making that change together. There's work within the PCN, which obviously that they will be heavily involved with, but we've also been, Michael and I have been quite kind of keen to have our leads involved in slightly wider pieces of work. So we've kind of very clearly listed all the different work streams. There are millions of them, but there's a few that we think that having that primary care voice is really important. Like, how to assess patients, how we're going to use our new HCAs within our systems to improve the physical health of our mental health patients, as a few examples. And then so those are borough-wide work streams. But if we can get the leads to get involved in each of those, then we have a clear primary care voice in all of that. So it's kind of, as I've said, it's about making that change together. So hopefully, and I think Shahzad is your PCN lead, and again, so they will. So I would encourage everyone on this call. I think none of our leads unfortunately could make it today, but as each of you know your own who your CD is and what to go to them for, know who your PCN mental health lead is, and build that relationship, start liaising with them, and hopefully they'll be doing the same to you. Sorry, yeah.
Just to ask, in terms of as a practice or as a clinical director within the PCN, what exactly liaison work is it? Because the pathway you've quite clearly demonstrated on your slide is a two-way pathway, isn't it? That's already in place now. And so the referral comes in via the email to your teams, and it's either crisis team or it's the general team. But is it about potentially using that one session, which is quite a hefty amount? So our clinical leads across the system for North East London get one session to run diabetes, for example, potentially.
Absolutely.
So it was just a huge resource, but could we not revisit that so each practice could get a component of that to encourage them to turn up at the MDTs that are running in mental health? Because at the moment, the consensus is actually that it's not well attended as such across the whole of the borough, because it's not a funded component. So instead of using just the one mental health lead for their own practice potentially, but splitting it across so we can all engage with the service and really make it happen, because we've got from now till April that funding available. Just to revisit that, I think personally. Do you know what others feel?
Yeah, I wonder, Imran, I just got a couple of other questions. Shall we see what, and you might want to reflect on Anil's question as well, or comments there. So I can see that Helen and Tammy and Manuel. So if I come to Helen first.
Thank you. I'm sorry I can't write in the chat for some reason. I just wanted to ask how we can best support the implementation of this. I mean, I know that there's such a lot of activity in general practice at the moment and lots of new roles being introduced. What would you recommend? How can we support you most in terms of embedding these?
Do you want to get the other questions first? Shall we do that and then get some feedback? So Tammy, did you want to come in, and then I'll come to
Hi everyone. Thanks Imrana and Michael. Sorry and apologies, I missed the very start of this, but for me I'm not getting the purpose of the huddles. And what's difficult is, I think, as Helen said, how are we going to, sort of engage everyone in the process when we haven't really got clarity about what the huddle is for? So is it partly educational? Is it partly a referral process? Is it partly for us to be able to come and discuss, cases that we're finding difficult, but we're ultimately going to manage? So I can only compare it to the diabetes model that I understand. But Anil makes a point. If we do want engagement, we need to fund the time for everybody to get the cases and to come to the huddles, or else it becomes an arduous task and our transformation fails. So I really think that the purpose and what we were hoping to achieve, I'm not getting that clarity, and forgive me if everyone else is, but I'm struggling with it, which is why I'm finding it hard to then promote the engagement process with it.
Thanks, Tammy. And then Manuel, did you want to ask yours? And then I'll come back to Michael and Imrana. And I think there's also a question around the ARS recruitment from Kavita that you might want to reflect on. So Manuel.
Yeah, hi, thank you. I've got a couple of questions. One is regarding the additional staff and roles you mentioned on the slide is 1 WTE per PCN. But the PCNs are actually, the population of the PCNs vary from, I don't know, 65 to down to probably roughly around 30, 35. So how is that going to work? And my second question is where we've been talking about these integrated care systems, and there are other MDT meetings, loads of MDT meetings that goes on, and how this how the mental health patients, if they are on several MDT, how their care is going to be coordinated across the different MDTs, because I'm thinking about holistic care here, integrated care here for patients who could be on several MDT space.
Rana, do you want to, and then Michael, you might want to reflect on those various questions. Thanks.
Okay, thank you guys. So there's lots in what you've asked, and I've nothing kind of I've heard these things before, and these are things on our radar. So I'll try and kind of perhaps put some of these questions together. So Anil's and Tammy's about the huddle and using resources. Again, really valid questions, because you are the front line who are seeing these patients going in the huddles. I think our key was that it was a really good question about the purpose of the huddle. So the purpose of the huddle was about kind of as described, better and quicker access to specialist advice, building that relationship between primary care and secondary care, and dissolving those boundaries. And what we had thought was that the beauty of the huddle is that it's not like an MDT in the sense that you have to sit there for the whole hour every 2 weeks. If you have a patient to discuss, you go in, you jump in for that patient, discuss that patient, have an answer, and jump out. If you don't have a patient, you don't have to attend, but there is that kind of added kind of side effect of it being really good for training and for learning. So if you do attend, you do learn a lot. So I mean, we did have we've had lots of discussions about huddles, and one of them was about, should we even scrap them, as long as we maintain the kind of purpose of the huddle. If we can do that in different ways, and different PCNs want to do it differently, we're still open to that. But what was felt, that those who do engage with the huddles, they have found it so useful that it just feels like it's just like once you get involved in the huddles, you will find it useful. So in terms of resources, again, we have looked at the kind of resources and what's available, and you'll probably be aware the SNS, we have put in for this year's SNS some money to go to attendance of those huddles. So we have listened to that concern, and then we have put that in place. I mean, I don't want to go into all the details. It's not a huge amount, but it's what we could manage, and it's for this year, and then we'll have to relook at it next year. So there is resource going in specifically to that, and that's specifically after kind of the concerns that you all have raised to us before. And again, just about the GP clinical lead role, again, we can look at that, but I think because this is a PCN model, it doesn't make sense to split it up by practices, and then having a GP clinical lead is so much kind of upskilling that can happen within that space, and as I said, having that primary care voice within the system. But yeah, so that's the thoughts at the moment, but again, open to different ways of working if people have different solutions for particularly within the PCNs. In terms of the MDT and sort of how it fits in with the wider MDTs, again, we've had lots of discussions about this as well, about how, I mean, I can see that it can sometimes feel a bit fragmented. If there's a mental health MDT, diabetes MDT, we have our monthly ones, and it's the same patient that we're discussing in all of them. But it's that balance, really. It's kind of a tension. It's about having enough space to be able to discuss patients properly with the right skill mix within that MDT, but and not having one huge meeting that goes on for hours with lots of people that don't need to input. So it's about finding that balance, and again, willing to listen to solutions. But this is what we've got at the moment. And Helen's lovely question about how we can help. So I just, again, I'm being really ignorant. When you say we, who do you mean?
The system, really. Where do you think it's going to be the most difficult, and who's best placed to help you?
So I think we like to think that it's not about helping, it's about doing it together. So that's what's been different about this transformation. And I think I agree things could have been done differently, and engagement and having that co-production in certain areas, particularly with with our LBN colleagues, could have been better initially. But I think the table is open. people within the transformation are very willing to hear ideas, hear solutions in particular from the people who know how things work. And again, it's an iterative process. There's lots of meetings. If anyone would like to attend any of them, you're very welcome to. You can touch base with Michael or myself. Yeah. And I guess just being open to that change, and any problem, solutions, ideas that you have, just feed back to us and feedback to the system so we can continue improve. I think I've answered most of them. Is that right?
Thanks, Imrana. I'm sort of hearing there's possibly a need to review this again a little bit, because, you know, I can see the conversation with Anil and Tammy. There's something about actually getting into the use of the huddles more effectively, getting the system up and working, and then maybe a little bit of refinement will be needed as people take that collaborative working forward. I'm slightly conscious that we probably need to move on in a second, but I can see that Dr. Medapali had got a specific question about a patient. So I don't know whether that is one you might want to take offline, or whether just liaise separately on that one. It feels like it might need a specific pickup.
Let me just read through it and I'll reply privately.
Okay.
Everyone. Thanks.
Thank you. And Rima, I think everyone would endorse Rima's comments that people feel very appreciative both of your time today, Imrana and Michael, but also the support that they've been seeing across the system. And I guess one of the positives about the engagement and the challenge is about people being really fascinated, really interested, really wanting to get involved in these things. So I guess the questions are built out of that, you know, enthusiasm to make this work as well as we possibly can. So please do take that messaging back. So if we move on, and I apologise, I should have said at the outset, we do record these sessions, mainly just so that we can capture a note and share it around the rest of the system. But we've got two contributions now around children's health, and people will probably be aware there's quite a lot of anxiety around what we might be seeing in the autumn and winter. So Ashley Teakle is with us from the public health team, and then we've also got a specialist contribution on bronchiolitis from a consultant paediatrician. So Ashley, did you want to just start with your thoughts in terms of the public health agenda for children?
Great, thank you everyone. Hi, lovely to meet you all. My name is Ashley. I'm a public health strategist in Newham's public health team, and I lead on the maternity and 0 to 5 portfolio, but some of my remit does go into the older age ranges as well. So I'm not going to give you a complete update on children's today because we would be here forever, but I've chosen two main topics that I think might be of benefit and value for you to hear about. So the first one will be on immunisation, and the second will be on our 2 Healthy Start schemes that are currently we're offering in the borough. So if we can just move to the next slide, thanks. So I just wanted to preface all of this by saying that all of the work that the public health team does is or informs and is founded by the health and wellbeing strategy. So Newham published their 50 steps to a healthier borough about this time last year, I think. And this strategy, if you don't know already, is comprised of 12 priority areas. I'm responsible for priority 1, which is enabling the best start through pregnancy and early years. And the other priority area that is specific to children is priority 2, which is supporting our young people to be healthy and ready for adult life. So there are 5 key steps under priority 1. I won't read them all now, but as I've said before, if we just click, I think 3 more times, please, you'll see that the focus today is on immunisations, which relates to step 5, and then step 3 and 4 relates to Healthy Start. Next slide, thanks. Okay, so I wanted to really give you a high-level overview with regards to some of the key work that we are undertaking around immunisation, and kind of what we're hoping to do through all of this work is get to the point where we have developed an action plan and we're really clear as a group of partners what needs to happen to help you, in particular, increase the uptake of childhood IMS. So there's been a number of different areas of work that have been undertaken. So we've recently developed a joint strategic needs assessment for children and young people. There is a specific chapter on this related to childhood IMS, and if any of you would like a copy of that, we can definitely send that through. And also, if you've got data or information that you would like inputted into that JSNA, we're also welcoming that at any point. Towards the end of last year, I and another colleague ran a series of deep dive interviews with about 17 to 20 people who make up some of the IMS system here in Newham. So that included some GPs, practice nurses, practice managers. We also spoke to head teachers within the school system, Vax UK, who is our school-aged vaccination provider, as well as health visitors, midwives and school nurses. And the point of this was to better understand how they viewed and understood the IMS health system in Newham, what they thought the strengths were and where they thought the areas for improvement lay. We from then did a workshop, which then fed into what we are now running, which is a monthly CYP IMS working group. And this group is open to anyone who wants to be involved in partaking in regular updates around childhood IMS. We do have a practice nurse who's on that. We also have a primary care rep as well, but the more the merrier. So if you're interested to be part of that working group, please do let me know. So from all of those different bits of work that I've just mentioned, we are now in the stage of having developed a draft action plan. So what we've found through the deep dives, the interviews, the workshops that we did was that there seemed to be about 5 key themes where we thought that we might be able to do some improvement work on. So the first one is around strengthening pathways, and it became acutely aware through the research that we did that we needed to map the IMS pathway in Newham. We needed to better understand all the different partners in the borough and how they could possibly feed into each other as and when was needed. So for example, we had someone from primary care say, one of my families that come to my clinic, they just are refusing the vaccine. Is there any way that we can work with other partners in the system to have further encouraging conversations with that family? And we've since decided that we really need to strengthen referral pathways so that people such as yourselves know who the point of contact is in our health visiting team, for example, or in maternity, so that you can work as a group of partners to really provide families with that wraparound support that they need to hopefully get to the point where they're happy to have their vaccinations. Theme 2 is all around optimizing the role of data. So we heard from partners that different partners operate using different data sets and they may collect data differently. Some of you also mentioned that you don't feel like you have access to all the data that you need to be able to truly understand uptake in your patch. And that's something that we definitely want to work with people such as yourselves on to try and improve. The third theme is around comms and engagement. So again, trying to work as a group of partners to better understand what are the key messages we want to get out to families. And more importantly, are we all giving out the same messages? So is maternity giving the same messages as health visitors? Are health visitors giving the same messages as GPs, for example? The fourth theme is around learning and development for professionals. So we had a practice manager, for example, say, what do we do with families who are just refusing their vaccinations? And one of the ideas that another partner had was to run some training sessions with interested professionals around how to have encouraging conversations with families. We actually ran how to have encouraging conversation training session for the COVID vaccine, and that's been really, really effective in many different areas. So we're looking to start to bring that into the childhood IMS space as well. And of course, it would be open to professionals such as yourselves if you would find that helpful. And theme 5 is around expanding the role of settings. So as an example, Vaccination UK now provides the BCG vaccine. They had 2 community centres that they were doing this from, but we are now using 3 additional locations to offer the vaccine as well. And we've actually decided to use children's centres. So again, it's about the role of how do we expand the number of settings in which families can access this opportunity. We are also working with another clinic within Newham who is going to be piloting an expanded time in which families can come and get their immunisations, and that's happening on a Saturday. And if that goes well, we'll look to see if you'd be interested in rolling that out further. So next steps is really just about trying to get the ideas and thoughts from as many partners as possible around which of the actions embedded in this action plan do you think we can just hit the ground running with and get moving on straight away? And then what are the more long-term areas of systems change that might take a little bit longer to achieve? So if you're interested in contributing to the further development of that action plan, or if you've got ideas or specific requests, if you're interested in maybe being part of some pilots, please do email me. My email's on the slides there and we can chat further. So the next bit of my presentation, if we just move on, is around Healthy Start. So there are two, I'm going to try and break this down into two key areas. So there's the Healthy Start National Scheme, and I'm going to focus on it being a food voucher scheme. And then the second part we'll talk about is the new universal vitamin offer for eligible families, which has just become up and running in Newham in May. So I'm sure that so many of you are already aware, but sometimes it's nice to have a refresher of what these schemes are. So the Healthy Start Food Scheme is a mean-tested government scheme, and it's designed for eligible families who will receive up to £8.50 per week per eligible family member, and they can use this money to buy fresh, healthy food such as fruit, vegetables, tinned items, pulses, as well as infant formula. Next slide. So at the moment, the Healthy Start Food Scheme is available to pregnant women and families who have at least one child under 4 years of age, but they do have to be on certain financial benefits. It's also open to all pregnant women under the age of 18, and they qualify regardless of whether they're on benefits or not. So there's some examples on the slide there of the types of benefits that families might be on. But really, you can pretty much guarantee that if they're on some type of income support or benefit scheme, they'll be eligible for Healthy Start vouchers. This is really for later if these slides do get sent out. So there's just some simple and easy steps to follow about how you can encourage families to apply for this if they're interested. You might recall that previously a health practitioner has been required to sign Part B of the form. That's now no longer the case. So they've just transitioned into a new form which doesn't require the family to do that. You can also order forms online, and you can also get in contact with me and my colleague Asmat, who's leading on this area of work, will be able to order those forms for you. Next slide, thanks. So this is the final update for me today, and this is around the Healthy Start vitamins. So as of May this year, eligible families in Newham can now receive vitamins for free. And there is some eligibility criteria. So it's all pregnant women. It's also mothers with a child under 12 months of age. And it's also for any child who's under the age of 4. It's also important to remember that vitamins are halal and suitable for vegetarian diets, and they're also free from milk, egg, gluten, soya, and peanut residue, which are quite common questions that we get asked by residents. Next slide. So again, I won't go into too much detail other than to say that when you get a copy of these slides, you'll be able to click on the hyperlink underneath the map on the left-hand side, and that will take you to a list of distribution sites located in the borough. We have a mix, so we have most of our children's centres provide these vitamins, and they're drop-in centres, so families don't have to book. Families can also speak to their health visitor, as well as some clinical practices, but those are typically places where you would have to book in to go and collect your vitamins. And these are some information flyers. So if you would like to receive these either by email, or if you would like us to organise to get these printed and mailed to you to distribute to the residents that you work with, again, please contact me and I will get my colleague Asmat to have a further discussion with you about what you need and how many. The other thing to mention is that Azmat, my colleague, runs more detailed information and training sessions on both the Healthy Start voucher food scheme and the vitamin scheme. So she's running, I mean, we can tailor make it. So if you want a half-hour session, she can do that. If you want an hour or a 2-hour session, she can do that. And she goes into further detail about what these schemes actually involve, how to get people onto them, but also more of the health promotion, public health benefits of things such as the vitamins and healthy food, etc. So please do just give me an email. My email's on the next slide, and we can go from there. The only other thing to say is that I've missed Helen. Helen was going to come in and talk a little bit about the IMS coordinator role. So as part of kind of actioning some of our action plan, we've recognised that we really need a bit of a coordinator to help us with this. And Helen, I think you wanted to talk a bit more about that.
Yes, thank you, Ashley. It was a great presentation. I just wanted to let colleagues know that we've had the opportunity of recruiting a Band 7 half-time equivalent individual. It doesn't need to be a clinical individual, but it needs to be an individual who's interested in children's immunisations, who has some primary care experience, to work with us to support the immunisation uptake in Newham. As we know, lots of our targets are off kilter at the moment because of COVID. So we've put the advert out once across the practices. We're reaching out to use the opportunities in LBN and also NHS jobs. But if there's anybody out there who's interested in working with us for a year, please feel free to drop me or Ashley a line. That's it, really. Thank you.
Thanks, Helen, and thanks very much, Ashley. I see you've been able to respond to the question about children's centres being all open, so that's really helpful. Manuel, is that a legacy hand, or do you got a quick question?
It's not a question, it's just a suggestion that something that I started working on but never got to finish is I started a project called From Conception to Year 5, which actually looks at holistically the entire family, because from a practice point of view, this covers a CQC area as well, in terms of how a mother would, or the parents would, go through the pregnancy, and then up to the 5-year-old, and the childhood immunization and the advice to follow to, again, it's a public health. The LARC is actually a public health contract. So how you can actually signpost the mum to these areas. So, and I developed an integrated template for EMIS. So, but it needs to be kind of, so I would be quite happy to join your forum or whatever it is to see how we can help the general practice to approach this in a more kind of a family thing, because what I found is 6 to 8 weeks checks plus the immunization has a greater, chance of uptake of immunization, and also helping the mothers to cope through the postnatal issues. So I would stop there, but I'm sure most of you probably understand what I'm trying to get at.
Thank you, Manuel. That's really helpful, and a volunteer, Ashley, to take forward some connections. Can I suggest that we move on